Thank you again, everybody, for joining us today. We're very excited about today's presentation. A couple quick housekeeping items. So we will have a question and answer section at the end of the presentation. As the presentation is going through, if you do have any questions, please put them into the Q&A section or into the chat box. We will be moderating both. And as I mentioned, we're very excited about the presentation today. We have Dirk Muller joining us from Osnabrück University in Germany. He is going to talk with us today about implementing objective clinical reasoning in medicine and therapy. And so I will go ahead and hand it over to Dirk. Take it away.
Okay, thank you, Zach, for the nice and warm introduction, and thank you, Nork, for the possibility to have this presentation. I hope you will like it. We will see. So before I start, I have to work. Okay, before I start, I would like to have some words where Osnabrück is. Maybe some of you don't know Osnabrück. From my point of view, Osnabrück is more or less in the center of Germany. It's my opinion, but it is not. It's in the northwest part of Germany, close to the Dutch border, in between the line of Amsterdam and Berlin. So normally we have here rain and cloud. Today it's a little bit sunny, but it's the northern German weather. But it's a nice town, a small town with 200,000 people. If you come to Germany, please join me in Osnabrück. I will be very happy. And for my person, I'm a physiotherapist and sports scientist. I studied sports science at the Sports University in Cologne. And I live in the two worlds of physiotherapy or physical therapy and sports science. And I'm specialized in manual therapy. I got a degree on the IFOMP level. I'm very interested in clinical reasoning. So how do physiotherapists work? I'm absolutely interested in motion analysis, more or less the instrumented analysis. And we have in Osnabrück, we have big research topic is musicians' health, and I'm very involved in this topic. So this is also one of my favorite interests. Okay, today I would like to talk about clinical reasoning and biomechanical analysis. It's very interesting to think about the ways how to implement biomechanics into the clinical reasoning process. It's easy, I think, but it's not. It seems sometimes it's a little bit complicated, but we will see. We develop a multi-level model. We means me and my good friend and colleague from Cologne. We developed a multi-level model. It's a proposal to implement this biomechanical stuff into the clinical reasoning process. I just want to make this clear in a few slides, and then I go over to two case studies to make this clear with clinical examples. Okay, here we go. One slide for my home place, my Osnabrück University of Applied Science. So what you see on the slide is we have two big areas. We have research activities, physical therapy research activities. For example, we have this motion analysis. We have a big motion lab. It will increase in the next year. We have got a bigger one as we have it now. One other topic is musician health. Other colleagues do research on neuropathic pain, emotions and pain, or craniomandibular dysfunctions, all from the physical therapy point of view. And we have students from all over the world. We have 4 bachelor programs, we have 4 master programs, and additionally we have the possibility for PhD students to do their PhD degree at our university. And my passion is to bring both together, bring the research activities and the students together. So this is a point, motion lab and physical therapy. So my idea is our students very often read articles, papers, studies, and where the assessments were some kinematic or EMG devices, and they saw all the curves and the results. And I like to talk about that, but also give them a theoretical introduction, and then they have to work in our lab practically with the devices. So it's not only theory, it's very important to have a small theory part and then a big practice part, that they got their own experience, maybe with the EMG and how to implement it into the clinical reasoning. So, and I would like to talk about that. So what is clinical reasoning, and what is the challenge for us to implement biomechanical analysis into it? So you see on the right side, you see it's in figure from Edwards and Jones from 1996. It's an old one, but it's the whole complex algorithm of clinical reasoning. Keywords are practitioners, we collect, evaluate, and make judgments about a diagnosis and management of patients' problems. So that's the idea. We got informations, we judge, we evaluate the information, we generate hypotheses, and then we make judgments. What can we do? Then we treat the person, we make reassessments, maybe we modify our hypothesis, and then we go on. So let's think it's a kind of a wise action. So we get the best from the patients, the evidence, and the current therapy. So this is a typical physiotherapeutic clinical reasoning process. But on the other side, we have this stuff, the devices. We have kinetic, kinematic, muscle activity. We got a lot of things, a lot of sensors, a lot of electrodes we can put off the body. And how can we bring it together to have an the best value for the patient, for the treatment? That's a big question. So we have some challenges. On the one side, we have the physical therapy and medicine, and on the other side, we have the sensor-based biomechanics. So due to my experience with my students and to my own clinical experience, there are some challenges we have to solve. First of all, at which time point sensor-based biomechanics should be used? This is very interesting. So should we use it at the beginning of the clinical reasoning process, or at the end, or how often we should use it? It's very interesting. Which sensor-based assessment is useful? So if we have maybe a patient with low back pain, should we put on everything we have? Kinetic devices, markerless, marker-based, or kinematics, or muscle activity? We can use a lot of assessments. It's fun, it's nice, but is it useful? Maybe less can be more. So maybe as one small single biomechanic device is more useful than the whole battery I have in my lab. The same with the parameters. Which parameter should be analyzed? We have a lot of parameters, as you see it here as an example: amplitude, frequency, on offset, center of pressure, whatever. But do we need it for the treatment of the patient to get more information, or is it more relevant to have this one or maybe two parameters that support our hypothesis? That maybe is more useful. Another question is, what about the time management? Especially in Germany, the physiotherapists have always, without biomechanical analysis, they have time problems, because the normal treatment time is between 20 and 30 minutes. Maybe in some clinics they have 1 hour, so it's not that good time. And how can we implement biomechanical assessments in this small time period? And what about the interpretation of the biomechanical data? It's also a key point. Are the biomechanical results, the biomechanical data in the center of the whole process, or is it just a tool to support the process? So it's the kind how I interpret the data to support my hypothesis, or do I have the biomechanical data and put the results of the normal clinical reasoning process into the biomechanical data? So it's another interesting question we have to think about. Okay, just an idea. And how do I work with my biomechanical stuff, with my clinical reasoning? As I mentioned in the third slide, we developed the multi-level model. And the idea behind that is to have a kind of a red line, or a good way how to to use biomechanical data in my process. And this is a typical multi-level model. You see 4 levels. At the beginning, it's the anamnesis, so the interview with a patient, and maybe I got some other diagnosis from the physician or from other healthcare professionals. And based on this information, before I start with my physical examination, I develop a hypothesis. I think based on this information, the patient has this problems. I think that based on my hypothesis, I start my physical screening. Sure, I got my visual inspection, functional testing, active, passive movements. I got motor function analysis, posture balance things, all the things I can do, but without biomechanical devices. I just look what can I see, and based on this, maybe I see I recognize some suspicious values. So some things is not going. Something's going wrong. Maybe the balance is not correct, or the left-right judgment is not correct. So based on this, I can decide, okay, based on this, I have a decision for an appropriate method. Maybe I need a kinetic analysis, maybe if I want to check the balance, the kinematic analysis, maybe if I'm interested in joint angles, or the neuromuscular analysis. Maybe I'm interested in how does the muscles work. So I have a targeted biomechanical analysis. So that's the first point. I don't need everything. Maybe I saw that you got some problems in knee joint stability. Maybe it's not useful to use a kinematic or a kinetic analysis. Maybe based on a hypothesis, the neuromuscular analysis is more efficient, because I think, or maybe the hypothesis is that you got a motor control problem. So then I can run my targeted biomechanical analysis, and maybe if the results doesn't fit to each other, I have to discard my hypothesis. Okay, the idea was wrong. I need another hypothesis, another idea, and then I have to run the same algorithm again. Or otherwise, maybe I can confirm my hypothesis. And if it's so, I have additionally, with my biomechanical devices, I can run additional therapy with my sensor-based biofeedback. So it's additionally possibility in my therapy process. So one key sentence is the application of sensor-based technology should always be aligned to the hypothesis developed in the clinical reasoning process. This is central. I need a hypothesis to have a target clinical reasoning process and implement biomechanical assessments. Very important. Okay, let's have a look for my first case. This is my good friend from Cologne, Kevin. He likes to surf. Hi, Kevin. Here's a known cartilage damage on the right knee joint. He had an accident in September 2018, windsurfing accident. He got crashed in the waves, and the rear fin of his windsurfing board slits into the suprapatellar part of the right knee. He got 12 stitches, and the measurement was 12 days post-accident. So here's again the body chart. Here's a local pain above his patella. So main problem was pain and a restricted knee motion, limited flexion here. So his pain behavior was knee flexion 9 degrees. Then he has knee pain, it's a P1 pain. Squatting and stair climbing, he got a tension feeling in the ventral knee area. During normal walking, he has no pain, and sometimes he has an unstable feeling in the right knee joint. Okay, as I mentioned before, past history, he has a known cartilage problem of the right knee. And additional information, he had a partial muscle bundle rupture of the right VMO that was MRI confirmed, and has a medial capsule effusion. Okay, that's the situation. So if we put everything in this multi-level model, hypothesis based on the information, my hypothesis was here's an arthrogenic muscle inhibition and a motor control change of the right knee. to protect the injured niche structures. Makes sense. He has an acute injury, 12 days past accident. Everything has a partial muscle bundle rupture, so everything is the wound healing process, and the idea of the brain is we have to protect. So inhibition, motor control changes make absolutely sense for this patient. So if you look for the general screening, if you do some task, first of all, standing in an upright position, and if he's squatting, you do some squats. What can we see? You see the white midline. We see he's standing slightly more on the left side. Maybe you can see it not on the video, but he's standing more on the left side. And if he do the squats, he has a slight shift to the left side. So based on this, our idea is detailed biomechanical analysis. We have two possibilities or two ideas. Of course, maybe it's a balance problem. So we can use a kinetic. We can run a kinetic analysis. We use a force plate. Otherwise, due to the muscle activity idea of the hypothesis, we check the muscle activity with the EMG. And if you consider the general screening and the hypothesis, the decision was very easy. So we use the electromyography. Okay, here you can see a measurement, just normal squatting. You see in the picture above, in the upper picture, you see the VMO and the VMO on the left and on the right side. And in the lower graph, you see the VL on the left and on the right side. Directly, if you look at the activity, you can see that the activity on the left side is much higher than on the right side. This was expected. If you look for the data, I have I run two reports: the side comparison report, just easy report, check left and right side, and on the other side we have the average activation report, where I put all three squats together with the standard deviation. And there are three things I checked. First of all, the signal pattern. Just look, how does it work? We see if on the left side, the VMO and VL on the left side, we see a clear pattern. If he starts his squat, we see an increase in activity and he goes back to his upright position, the activity goes down. That's the things I personally expect. But on the other side, the VMO and VL on the right side, we have more a kind of noise. It's noisy. You see, maybe with some fantasy, you can see, okay, we see a small activity, but not really a good activity. It's not very clear. So the signal pattern is more or less noise. If you look for the timing, when do the muscles start to activate in comparison with the picture? And if I compare it, I see the squat starts the activity starts in the right moment and ends in the right moment for the VM and VL on the left side. Same on the right side, the VMO and VL on the right side, we don't see a real good timing. So it's based on the noise, on the signal pattern, it's not clear to see a good timing. And last but not least, the amplitude. Check the amplitude. So if you look on the right graph, right figure, this is very interesting if you compare the ratios. I like to work with ratios. If you check the ratios within a leg, so the VMO and VL on the left side compared with on the right side, we see on the left side a ratio from 1 to 2.2, and on the right one, 1 to 3.5. So the activity of the VMO on the right side is lower than on the left side. Maybe in the literature it said that the ratio perfectly is 1 to 1, but that differs from study to study. So maybe his normal ratio is not 1 to 1. It's more that the VL is in general more active. But we see that the VMO on the right side is less active, so that we have the bigger ratio. If you compare it between the legs, we see the VMO on the right, on the left side, it's much higher on the left side than on the right side. The same with the VL. So we see differences. Here, just a side note: for the evidence. As I mentioned before, the ratio, it's not only this 1-to-1. It's maybe for a theoretical part, it's a ratio we would like to have or we expect, but it depends on several aspects. Just a few articles that stated that the ratio differs as an example, depending on the squat exercise or backward walking in female athletes with patellofemoral pain syndrome has a different ratio. So there are several things that can influence the activity, the ratio, and the activity with the VMO, that it increases after pain. Yeah, we have a lot of papers stated that the activity of the VMO decreases, but we also have papers and we also have research that the activity of the VL decreases. So this may be very interesting, that we don't only have to focus if somebody has knee pain, that the VMO is decreased. It can be the other way around, that the VL is decreased. But here in this case, we see that the VMO decreases. Okay, another evidence or another idea, just to bring it to the neurophysiological and neuroplasticity aspect to have an idea of it. This is a very nice model of Hodges and Tucker. They published it in 2011. It's based on a theory of Lund in the 90s. It's a theory of a motor adaptation to pain. It's very interesting, and I like this also to explain it to my colleagues and also to patients. So the box at the top, the pain injury or threat of pain or injury, that leads to changes from the motor cortex down to the motor neurons that feed the muscle fibers. So we have changes on different levels of the nervous system, and these levels lead to a redistribution of activity within and between muscles. And so we can explain that the VMO-VL ratio changes depending on the input from the central nervous system. Due to this case, we expect a kind of stiffness. You see it, this short-term benefit. It makes sense that the muscle ratio and the muscle activity changes. The idea of the brain is I have to protect my knee joints. So we need a stiffness. This is a short-term benefit to protect the injury. But the longer it takes, and the longer this wrong distribution takes, the more the consequences are. So the longer it takes, the higher the load for the joint is. The movement abilities of the joint or of the leg goes down. The reliability to interact with different situations goes down, and this triggers the pain injury or the threat of pain and injury. So it's a kind of a vicious circle. Just some side note to evidence that neurophysiologically. So in summary, with the first case, we have this hypothesis of the arthrogenic muscle inhibition and motor control changes. We see that. We use the EMG as the appropriate method. The EMG data confirms the hypothesis, and additionally, it supports the therapy. I don't want to give so much information about the therapy. This will be in the next case. So just as a quick summary, so this EMG data provides a quantitative confirmation of the hypothesis. This would otherwise not possible to see this motor control problem. And due to the hypothesis, we decided to use the EMG, not kinetic analysis, because we have a lot of muscular factors, a lot of information that as a consequence of the injury, the primary source were the EMG. And in the course of the treatment, the clinical improvements correlated with the muscle activity parameters. So the better the ratio becomes, the better was the clinical results, or other way around. We don't know which is the hen, which is the egg. So, but EMG data becomes better, clinical results becomes better. Okay, this was the first case study just to get an idea how I like to work with this multi-level model. So it's a clear red line that I can follow to get a good idea which kind of assessment I use, and we see I've got a lot of very important information. Otherwise, that won't be possible. Okay, so let's have another look on at another knee. Now it's an ACL rupture of a recreational soccer player. He's not a professional, just a soccer player, just in the evening with his friends. And I'm absolutely happy about this case because this is not my case. And I'm very proud of it because this is a case of one of my students. In this case, my student shares his defense of bachelor thesis, I think 2 weeks ago. So it's fresh data. And she was a bachelor student of mine. She was physiotherapist, but she was not experienced to work with the biomechanical stuff and was not experienced to work with the EMG. And her thesis was about implement an EMG into the normal clinical reasoning process on a real patient. On a real patient. So she was physiotherapist, that was fine, but she got 2 or 3 training sessions with me in our labs that I explain her how to work with the EMG, how to put on the electrode, how to clean the skin and all the stuff so that everything works. I give an introduction in the software and how to analyze the data. And then she put all the devices with her in her practice. She trained herself for a week or 2. Got some Zoom sessions and WhatsApp mail contact, but then she started working with the EMG, put it into the clinical work and analyzed everything, got the conclusion, and that was her bachelor thesis. And I'm absolutely proud of that. That was a very good work. So that's also a sidekick. Okay, the main problem of this patient. He has subjective higher load on the left leg during several activities. He had 2 ACL ruptures, one in 2011. He was fouled by an opponent, accident during playing soccer, and a re-rupture in 2016. Just a sudden direction change and the knee was twisted and he got the knee rupture. He got 3 areas of kind of pain. So P1 is a local pain around the patella. P2 is just a weakness in the thigh muscles, in the ventral thigh muscles. And P3 is a numbness in the area, in the lateral area under the patella. The pain behavior is load dependent. So we have several activities where the onset of pain, where it takes a couple of hours, that the pain starts, and then it's P1 and P2. So here's the pain around the knee, and it feels the thigh feels weak. Here's pain relief through rest, just for a few minutes, then it was fine. But if he kneels down in end of range position, the pain onset is immediately. But if he's standing in upright position, the pain goes down. So typical, the pain is load dependent. So if we put this in our multi-level model, just brief ideas. We have the history of the ACL ruptures. We have the pain behavior. It's a typical on-off pain. If he starts kneeling, then he got this pain. If he's standing up, pain gone away. It's local pain. It does not spread out, not goes into the ankle or into the lower back. Maybe it's possible influence of muscle fatigue. This is possible due to the fact that the onset of pain takes 1 or 2 hours. So maybe it's a fatigue influence, a fatigue factor, and pain in the end of range positions. Here's a subjective feeling of instability in the right knee and a lack of strength in the right thigh. So, but also additionally to the wound healing process, there's no active wound healing. So it's finished. Based on this, we have same not the same in similar hypothesis than the first case, the muscle dysfunction and altered motor control, but in this case without current injured structures. So then we run the physical examination. What are the relevant results? Sorry for that. We look at the gait, the stance phase. On the right side is shorter than on the left. Same with the stride length. On the right side, shorter than on the left. We have run a dynamic stabilization test, the Y balance test, and we just we just calculate the mean difference between left and right of all three directions, and the difference was 26.7 centimeters. Is direction on the right side shorter. The qualitative judgment of the leg when you're standing on the leg during the test, the knee looks shaky or unstable, and so we saw an increased valgus stress. The strange does have a muscle function test with the hands. The right muscles are weaker than the left muscles. Palpation, you have this patellar mobility, it's right less than on the left side, and the iliotibial tract on the lateral side, we have hypertension on the right side. This all leads us to the device. It's to the device, the analysis. We use the biomechanical analysis. That makes sense. So, and we run a gait analysis and the lunges with the EMG. Okay. What are the results? On the in the upper right side, you see the physical examination results. Down, you see the gait and the lunges results. I would focus on the injured knee. What can we see? This is very interesting. We see just in the gait analysis, we see a ratio on the healthy side 1 to 1.04, so it's 1 to 1, and on the injured side we see 1.47 to 1. So the VMO is higher than the VLO. In the lunges, we see on both sides, left is the healthy side, a ratio of 1.83 to 1, and on the injured side, 3.2 to 1. So you additionally see that the VMO is more active than the VLO. Probably the VLO is less active if you compare the mean values. What also is interesting, you can see that the lunges on the left side, or the lunges on both sides, seems to have a training effect or an effect of the muscle activity on the VMO. So the lunges might be an exercise for him to train the VMO. We can see it on the left side. But if you have in mind that the VL has a problem, the VL had less activity, it does not make sense to train lunges because we activate the VMO. So, but we train the lunges. Just this picture now, it's both information from the EMG data and from the physical examination data confirms the hypothesis that we have a muscle dysfunction and an altered motor control. So what was our management strategy? As I mentioned, we trained the lunges. We want to train in these situations that he trained his muscles, but under the idea of a reconditioning of physical motor control pattern. We want to increase the VL activity to have a better ratio between VMO and VL. And we mobilized the patella in end of range positions because he has problems. His patella is less mobile, so he needs manual therapy. We run an EMG-based biofeedback strengthening program in lunges with weights, in leg press, in squatting, but everything with EMG biofeedback, because if he would work without biofeedback, this would be most of the exercise would increase the activity of the VLO, but we want to increase the activity of the VL. So with biofeedback, for him, it was possible to focus on the VL to keep the activity up in the VL and don't let the VMO increase. And additionally, clinical reasoning plan, additional screening of the ankle, hip, pelvis, lower back, and neural system. So the whole complex factors around the knee that can influence the knee problems. In total, we have a treatment period of 35 days. Number of treatment sessions was 6, and the duration per session was 60 minutes. So what are the results? Might be very interesting. I found that interesting, and I'm absolutely fascinating about that. Here are the results of the EMG data. If we focus on the injured side, just have a look at the ratios, the VMO and VL on the right side, pre-post in gait from 1.5 to 1. Now it's 1.1 to 1. So the ratio is theoretically perfect. If you look for the lunges, pre-test, before the treatment for 3.2 to 1, and post-treatment we have 1.08 to 1. So additionally, this ratio is also close to 1 to 1. This is very interesting, and I like this graph because it works. Also, side note evidence on this slide. This is just some evidence that the EMG biofeedback training is a fantastic tool to get better results if you run strengthening training. So just three articles, 3 good articles that supports the implementation of EMG biofeedback in training the quadriceps. The other cases are meniscus osteoarthritis, and additionally anterior cruciate ligament reconstruction. So it works. And additionally, the nice thing is that we have in control. That we can control the muscle activity within the quads. We can lead the patients to activate more the VLO or maybe the VMO if necessary. Okay, just a brief look for the physical examination, the results. If you look for the post results, the gait becomes better, it's more left and right, it's close to each other regarding the stance phase and the stride length. The Y balance test, the difference goes down on 19.3 centimeters, it's close. It becomes better, but if it's significant, I have no idea. But it becomes better. So for me as physio, it's good. The qualitative results, it looks more stable and a less valgus stress. Strength test, right becomes better on both the hamstrings and the quadriceps. And the palpation, the patellar mobility is right and left more or less the same. And the iliotibial tract still unchanged. It's still hypertension. So if you bring both together, we see that the biomechanical data fits to clinical information. It's very interesting. So we have the possibility that we can quantify the physical examination data. Just maybe if you look for the gait, stance phase, or change, we have the possibility to quantify that. Or the motor control changes seems to be confirmed in clinical as well as in biomechanical data. So we see the patient moves better, he has a more stable skills when he's standing on one leg. We see it in the physical examination, and also we see it, this will also be confirmed in the EMG data. And as I mentioned, with the evidence, the EMG-based biofeedback training supports the regaining of physiological motor control patterns. So we have a perfect control of the muscle activity of the VMO and VL. For this patient was absolute necessary. If you wouldn't have used the EMG, you would train more or less the VMO with the lunges. And that means that we trigger the pathophysiological motor control pattern. So we need this EMG-based biofeedback training for this patient. Okay. Oh, last slide. Oh, time is running. Great. Sensor-based assessment. My take-home message. The sensor-based assessments support an objective clinical reasoning. I hope this becomes clear that we got more information, we got quantification of relevant parameters. Additionally, sensor-based assessment make clinical decisions easier. So we support or discard our hypothesis as necessary. Sensor-based assessment enable more therapy options. This is the thing with the EMG-guided biofeedback training. This is fantastic, absolutely fantastic. But this is maybe most important take-home message. But sensor-based assessments are only a small part of the whole clinical reasoning process and are not in the center of it. So never make the mistake to collect data with biomechanical devices and then put everything, or put the patient into the data. I have this experience in my first couple of years when I start working with my students. This is very interesting. Students work in our lab with the devices, and they collect a lot of data, much too much data. They got 16 muscles and have all the muscle data and starts to discuss the data and totally forget what is the real problem of the patient. What are your ideas? What are your hypotheses based on the other information? And so it doesn't work. So we have to break down the data, what is necessary, and then with this small information, but absolutely important information, we can improve our clinical reasoning, and that is the key message. It's a important but a small part of the clinical reasoning process. It makes the world better, I think. Okay, thank you very much for your attention. Greetings from Osnabrück. So that's it. Thank you very much.